Hi, my name is Marcus Carden. I'm a pediatric hematology and oncology fellow here at Children's Healthcare Atlanta. Today, I will be talking to you about initiating patient-controlled analgesia, or PCA, in patients who are in the hospital that have uncontrolled pain. As you know, this is a complex topic, but we will focus on a single case of PCA use. However, for more in-depth discussion, please refer to future talks. The goal of this talk is to have that audience understand how and when to use patient-controlled analgesia in a hospitalized patient. By the end of this talk, the audience should be able to answer the following questions. Where can you find the CHOA policy on PCA? What is one validated measure of subjective pain? How do you convert from oral to IV doses of opioids when initiating a PCA in a patient who has uncontrolled pain? And finally, how can you avoid constipation, an all too common side effect in patients on opioids, in a patient who has started on a PCA? The CHOA policy on PCA can easily be found on CareForce and is policy number 18.12. Per the policy, patient-controlled analgesia, or PCA, is used to deliver opioid analgesics to patients who are determined to be cognitively and physically capable of utilizing this approach to pain management. So patients who are in severe acute pain should be alert and able to press a button reliably for themselves to help control their pain. However, oftentimes the question comes up, are parents or nurses able to push the button for a patient who is in severe pain? The policy specifically states that parent-nurse controlled PCA is generally not recommended, but may be used with certain patients as determined by the physician and requires an attending physician order. So to demonstrate the appropriate use of PCA, let's use a case presentation. We have a 16-year-old African-American male with hemoglobin SS sickle cell disease who presents to the emergency department with chest and leg pain along with cough and fever for the last 24 hours. He's been managing his pain crisis at home with water and Gatorade, scheduled ibuprofen, prescription Lortab, as well as heat packs to his chest and legs. He has a past medical history for acute chest syndrome 3 times requiring hospitalization, as well as elective splenectomy and cholecystectomy. On physical exam, the patient weighs 60 kilograms, is febrile, tachycardic, tachypnic, hypoxic, and normotensive. He's in obvious pain, clutching his chest and intermittently his leg. He has obvious scleral icterus. He's tachycardic and has a notable 3 out of 6 systolic murmur throughout his precordion. He's also tachypnic and has crackles noted in his right lung base. When the patient was asked to stand up and walk, he had difficulty bearing weight on his left leg. Using a validated visual analog scale, the patient was asked to take a red pen and make a line on the scale demonstrating how bad his pain was, either to the far left, noting no pain at all, or to the far right on this scale, which suggests that he has pain as bad as it could possibly be. Using the red pen, the patient marked a line all the way to the right, indicating that his pain was as bad as it could possibly be. Another validated scale that is often used in the emergency department is the FACES scale, where a patient is asked to circle or point to a cartoon face indicating the pain that they're having at the time of assessment. The patient had blood cultures drawn along with a CBC and a CMP. He had a leukocytosis with neutrophil predominance. His hemoglobin was 7.1, which was near baseline based on review of his outside clinical record chart. His reticulocyte was high, as was his indirect bilirubin, indicating ongoing hemolysis. His other CMP labs were normal. The patient was urgently sent for a chest x-ray, where it was noted that he had an infiltrate in his right lung base, suggesting the patient had acute chest syndrome. He was started on IV antibiotics, also given oxygen for his hypoxia. For the pain, per protocol, he was given intranasal fentanyl and IV ketorolac. However, his pain remained a 10 out of 10, and thus morphine at 0.1 milligrams per kilogram was ordered, and the patient's pain improved to 8 out of 10. So in review, we have a 16-year-old male with sickle cell disease now being admitted to the hospital for acute chest syndrome and associated pain crisis. On the inpatient side, the patient was started on oxygen, as well as aggressive pulmonary toilet, which included scheduled incident spirometry and albuterol. He was continued on antibiotics, as well as hypotonic IV fluids at 3-quarter maintenance. He was continued on IV ketorolac every 6 hours for approximately 30 doses, and also scheduled morphine 6 milligrams every 3 hours. However, 24 hours later, although the patient's fever was gone, his heart rate and respiratory rate and hypoxia had improved, he was still uncomfortable gripping his left hip and leg and in obvious pain. Using the same visual analog scale that was used previously to assess his pain, the patient again was asked to use a red marker to mark where his pain was on the visual analog scale. Although the pain was a little bit improved from when he initially was in the emergency department, it was still fairly obvious that the patient was in a significant amount of pain and the scheduled morphine he was getting just wasn't cutting it. Thus, it was decided to convert the patient to a PCA. First, a 24-hour dose of opioid use for this patient was calculated. It's a simple mathematical equation. So the patient was getting 6 milligrams every 3 hours, and so multiplying 6 by 8, we got 48 milligrams given over the last 24 hours. And then, putting on the PCA, we need to determine what the continuous rate was going to be, also known as the hourly dose or the basal rate. So, taking 48 milligrams and divided by 24 hours, this gives us 2 milligrams given as a basal rate every 1 hour. Now, this is different from the PCA amount, which is going to be the amount that the patient gives himself when he pushes the button. Typically, we take about 50 to 100% of the hourly dose and use that every 8 to 15 minutes as the PCA amount. Being conservative for this patient, he was given 1 milligram, the option to get 1 milligram every 10 minutes as a lockout. At that point, you need to calculate either your hourly or 4-hour limit depending on the type of PCA you use. So for this patient, the hourly limit he would get is a simple addition equation. So 2 milligrams per hour as basal, plus he's able to get 1 milligram approximately 6 times an hour as a PCA dose. So this gives us 8 milligrams as his maximum dose every 1 hour. Now, the audience needs to remember 2 common side effects seen on patients who are put on scheduled opioids in the hospital are constipation and respiratory depression, both of which can be prevented. For constipation, patients who are put on a PCA should have also a scheduled bowel regimen consisting of preferably a stool softener and a stimulant. The choices that you can use are seen here. Furthermore, to avoid oversedation or respiratory depression, PRN doses of Narcan should be ordered for the nurse to use and to have at the bedside in case during assessment the patient is noted to have respiratory depression. Per the institutional protocol, again, policy 18.12, and this is part 2, section H. Respiratory rate and level of consciousness need to be monitored every 30 minutes for the first hour after PCA is started, every 2 hours for 4 hours, and then every 4 hours thereafter. With respect to the pain intensity, a scale needs to be used that is agreed upon by all providers of the department managing the patient. Pain needs to be recorded in the electronic medical record every 4 hours, more frequently if the pain persists. And then providers need to make changes to the PCA dose as necessary depending on these pain levels. So for our patient, 48 hours later, his pain dramatically improved after being put on the PCA. And actually, after 24 hours, the basal rate was able to be discontinued and he was put on 2 tabs scheduled Lortab every 4 hours. So after 48 hours of being on the PCA was discontinued and the patient was transitioned from 2 tab Lortab to 1 tab Lortab every 4 hours over the next 24 hours while in the hospital so his pain could be assessed and to ensure that he had no withdrawal symptoms from the narcotics. At that point, being afebrile, also with his hypoxia resolving and his pain adequately controlled on oral narcotics, it was decided to discharge him home and to continue 1 tab every 4 hours over the next 24 hours at home and then to take as needed if the pain were to arise again. Now this taper was specific to this particular patient and discussed with his primary provider, which is an important point to remember when transitioning a patient from a PCA back to oral opioids. Our patient was also continued on Sina and Docusate at home while on the scheduled opioids, and he also continued oral antibiotics and scheduled incident spirometry due to his acute chest syndrome that was diagnosed. The patient had follow-up scheduled in 1 week in the sickle cell clinic prior to discharge. So in review, Children's Healthcare of Atlanta has a policy on PCA use that can easily be found on CareForce. Remember, PCA is an excellent alternative to intermittent bolusing of opioids in a patient with uncontrolled pain. It can be easily administered, and it's safe in hospitalized patients who are awake and alert and able to push a button. And remember, you should always use a bowel regimen in a patient scheduled on opioids. And finally, a visual analog scale is a validated way to measure subjective pain over time. So remember, in your patients that are on scheduled opioids for chronic or acute pain management, to prevent constipation, you want to use a bowel regimen to ensure that you turn that frown upside down. Thank you for your time.